Warm welcome to this morning's Integrational Joint Board meeting. My name's Jennifer Adam. I'll be chairing this meeting. Just taking over from John. This will be the first time. So 2 wee seconds, something's popped up on my screen. So if we just go to apologies, do we have any apologies intimated, Elaine?
Yeah, I have apologies from Annie here.
Okay. Any declarations of interest? No declarations of interest. Okay. So that takes us on to item 1, which is the minutes of the last meeting. So that's pages 5 to 14. So I'll just go through them. And if there's any corrections or comments, just put your hand up. And if James, if you could just draw my attention, because I've got the kind of run order up just now, so I can't necessarily see everybody's face. So just keep me right there. So we'll start page 5, page 6, page 7, page 8, page 9, page 10, 11, 12, and 13. So no corrections or comments, everybody's happy with the minutes. So they're approved. And that takes us to the rolling action log. So the first item on the rolling action log is the NHS GGC's mental health strategy, the Renfrewshire implementation update. So what it says here is submit the update when available, when the funding allocation and evaluation of the activity within the 18 to 23 strategy is refreshed to 2027. So I believe that has been agreed at the NHS GGC board, and I believe it'll be coming to the next board in November. And the next item is unscheduled care winter update. So we're on track with that. There's work underway, and hopefully there'll be another update brought back in November. Next item, you've got the chair and vice chair of the IGB and the IGB Audit Risk and Scrutiny Committee. So submit reports to the relative appointments of the chairs and the vice chairs for the 2-year period. And obviously that matters is on this agenda. Next item is the Chief Officer's report, which is also forms part of Stuart Sutton, and it actually forms part of this agenda. Next item is the financial report. It forms part of this agenda. And then it's the draft annual performance report, which also forms part of this agenda. So that's our rolling action log. And then that just takes us into item 3, which is the Chief Officer's report. So Christine, I'll hand it over to you. I know it's always, you've always got a significant amount of work in here, Christine, you know, but it's all worth noting, you know, obviously from policy changes to general updates, but I'll let you pick through it, Christine.
Sorry, Councillor Adam, could I just come in very, very briefly? Sorry, just going back to the action log and the comments about the 2-year appointments.
Yes.
And a report coming back. Sorry, there was intended to be a report coming back. It was discussed at the last meeting. I was asked to bring a report back to this meeting. However, I haven't done so on the basis that since then there has been a question raised around the review of the governance of the IGB Audit Committee. So that's to be subject to a review of the internal governance. The Audit Committee have to do that themselves, and I want to try and pick that matter up as part of that. So I didn't think it was appropriate to bring a separate report back. So it was just to cover that off. Thanks.
Okay, Mark, thanks for that update. Cheers. Okay, Christine.
Thanks, Jennifer. So as you say, members of the IGB will be used to the Chief Officer's report, and it is quite weighty this time. So I don't intend to go through it all, but I will highlight a few key areas. It provides an update to the IGB on the developments and operational activity since we last met at the end of June, and any additional policy developments that the HSCP are required to build into future work plans, strategies or action plans. So the first area that I would like to bring your attention to is our winter planning that you mentioned from the rolling action log. We started very early this year, working closely with colleagues in the council and GG&C, particularly learning on previous years and ensuring that we have a big focus for us is ensuring we have robust business continuity plans in place across all of our services to ensure that we're able to continue to provide care and support and treatment to the most vulnerable people who rely on us. We've also strengthened our position with the development of our Home First response service. IGIB have been updated on that service before. It sits at the front of our RAH hospital, and its main aim is to prevent people who have a level of frailty from being admitted to hospital if they can have a wrap-round support at home. And that's a very successful service, and we've had really great feedback from the people who have been using that service. At item 5, it gives a summary of our drug and alcohol related deaths from 2022. Pleased to report 22% reduction in our drug deaths and a 21% reduction in our alcohol related deaths. However, I do want to say that every death is a tragedy, and our condolences are with families who have lost a loved one. We're encouraged by the reduction in numbers, and we hope to continue that. There's some detail at 5.3 of the actions that we are taking in relation to providing support for people who have got drug and alcohol issues, but also with a main aim to reduce the number of deaths. At item 6, the National Records of Scotland have also reported on 2022's deaths by probable suicide, and sadly it's not the same picture as our alcohol and drug deaths. That we have seen an increase from 25 people who have lost their life to 33 in 2022. So that is a 32% increase on the numbers in 2021. So I think everybody involved have been saddened by that increase, and we know that every death is a tragedy. So it has been widely documented, and we've talked about it at previous IGIBs, just about the impact that the pandemic has had on people's mental health. There's also strategy, the Scottish Government strategy on suicide prevention has charged each area with coming up with a multi-agency suicide prevention strategic group, and for that is chaired, that group for Renfrewshire is chaired by me. We had our second meeting last week. We've got a high level of commitment from partners, so that's third sector and key partners like Police Scotland. Part of that strategy is around what we can learn from people with lived experience, and we're looking to try and strengthen the lived experience input into that strategy. So at the moment we are at the action planning stage, and we report into the Chief Officers Group of the Council in relation to that. What I would say, although our deaths by probable suicide have increased in Renfrewshire, Renfrewshire still has the sixth area, local authority area in Scotland. It's sixth lowest death by probable suicide. So that will probably be little comfort to the families affected. Item 7 gives us some detail around our alcohol and drug partnership, which we are getting an update later this morning. But I did want to just welcome John Goldie to the meeting today. John has just been appointed as our independent chair for the alcohol and drug partnership. So a number of other, you'll know that we've updated previously around wanting to do something a bit different in Renfrewshire, and we've been reviewing what we've been doing around alcohol and drugs, and some other areas across Scotland had employed an independent chair. Previously the chair of the ADP was myself, and we did feel that there was a level of conflict there. And we thought that having an independent chair, similar to what we have in Renfrewshire around child protection and adult protection committee. So successful recruitment, and we're delighted that we've got John in post now. John comes with an absolute wealth of experience. People will maybe, his name will be familiar in terms of he led the whole system review just before I arrived in Renfrewshire, so I think about 6 years ago, and that was looking and reviewing what our drug and alcohol service. So John's very familiar with Renfrewshire and what services we've developed over recent years. So that's a real strength for us, recruiting John. Happy to take. Sorry, just last thing is there's also some details around COVID testing and vaccinations in the update. As always, happy to take any questions.
Okay. Well, welcome, John. We're very pleased to have you. And I believe there's another new face here today as well, Pauline Robbie, who is now the replacement for Jackie Dougal. So you'll meet Pauline later. She's coming in number 9, item 9, so you'll see her then. But very welcome to join. Right, so I see there's lots of hands up here. Ian's first. Ian McMillan, and you come in.
Okay, can you hear me okay?
Yes, I can hear you good, Ian.
That's fine. It's the first time I've done one of these meetings with headphones on, so I wasn't very sure if it would work. Anyway, just a bit about the drugs and the alcohol. It is certainly good news that deaths have went down. I'm not entirely sure why that is, but I know there is certainly a lot of work being done, a lot of positive work. And what I certainly like is a lived experience. I think that's a really, really good asset for us when we hear firsthand from people who have went through this situation. And I've been at a couple of seminars in the last 6 months or so, and I've met people, and it's been really, really interesting. But as Christine touched on, disappointing about the suicides. And again, I know there's a lot of work going on, and we spoke about this. I know this is a different forum altogether, but we did speak about it yesterday at Renfrewshire's full council meeting, and it's something that really concerns us all, not just as councillors, but people who actually live in our communities, and people like myself whose families have been affected by suicide just know how devastating it can be for the people who are left behind. So, you know, I appreciate any updates and any work and new initiatives that are going to be happening. We also spoke yesterday at the full council meeting yesterday about the consumption rooms that are coming to Glasgow, and I think all political parties welcomed that initiative. Some people have got their concerns about them, and they'll no doubt be raised at some point. But I think any tool that we can use to try and scourge Scotland and in Renfrewshire, the drugs issues, it has got to be welcome. And I'll look forward to finding out how these things get on. But it's a very welcome initiative. Thank you.
Thank you for that, Ian. Right, and Cameron Burns, you're next.
Thank you, Jennifer, for my full name there. I love it. Sorry. I'm looking at figures that are here. Christine, can I ask, do we have a breakdown on the age and gender of the people who have taken their own life through suicide? So I don't see it in here anywhere. Maybe I've missed it, but do we have a breakdown of gender and age?
So we do have a breakdown of gender, Anne. So for our 33 people who lost their life, 10 were women and 23 were men. In terms of we don't have a further breakdown around the age, but generally speaking, it's 25 to 44 and 45 to 64. And we're working on how we can get some more detail on that. Now, what we just to kind of, and this will cover drugs, alcohol, and suicide, is for the people who have completed suicide or people who have lost their life through drugs and alcohol. If they've been known to our service, we will do a review of that to see if there's anything that we can learn, if there's any missed opportunities of where we could have intervened or delivered our services differently. The challenge for us, and so for those people, we will know quite a lot about them in terms of their age, what other risks there may have been in place. But for the people who we don't know, we only will know very little detail if they've never came towards services. And I think that's one of the challenges around suicide. So one of the actions from of our strategy within Renfrewshire is around this. It needs to be a multi-agency response. Suicide needs to be everybody's business, because many people will be suffering in silence and will have, you know, it'll be kind of be in turmoil, but to the outside world are going about life and going to work, etc., and are not coming towards mental health services. So those are the ones that we, you know, really want to reach out to. So we have been providing a lot of training across all of the services within the council and also in GG&C, because we know that actually there may be missed opportunities there when somebody may just want that want to talk to another person around how they're feeling. So that's one of the challenges for us about if individuals are not known and accessing our services, we don't have a lot of detail about them. And we also do know, and this is the same for mental health, drugs and alcohol, a #1 protective factor for individuals if they are struggling around any of those areas is when they're engaged in meaningful treatment. So part of our job for all of our services is how we engage people in treatment, and we make that treatment stick in terms of our services.
Thank you, Christine. I don't see any information on young people and taking their own lives. We don't seem to have any stats on how many young people under the age of 18 who have taken their own lives in here, and there doesn't seem to be any information on how we're tackling that. And I need to, you know, my nephew took his own life a couple of years back at the age of 14. So I have a keen interest in what we're trying to do in regards to younger people within that. So I'm just wondering we don't seem to have any information. We've got it with people that, like it says, that have been involved in services and how we can support them. But I'm wondering what type of work are we doing in mental health within the schools that can prevent our young people taking their own lives, particularly young boys. It seems to be a figure. It seems to be quite high.
So we do have REN 10 within the council is a range of services that are supporting young children and young people around mental health. We also have our, as you know, our CAMS service. CAMS provide a service within Renfrewshire, but is now, as you know, Anne, is managed by East Dunbartonshire. I could look at providing, getting some detail around young people, if that's helpful, and just provide that. I can do that across the members out with this meeting, if that's agreeable.
Thanks, that would be great. Thank you.
Okay.
Okay. Hey, Jacqueline, you're next.
I don't know
Oh,
whether
sorry. No, I see. Sorry about that. I see Fiona's next.
Thanks very much. It was just because it follows on very nicely
Yes.
from Anne's point there just now, just in terms of I was interested in the gender breakdown and also the age breakdown, and in particular young people, because I think nationally we know that young people are at a high risk in terms of suicide or suicidal ideation. So I've got a few points, but if I could just kind of continue with that one. I'm aware of a project down in Borders where they are looking to tackle the issue where we have suicides with people that are not known to services by working with Scottish Rugby. So it's a third sector organisation that work with Scottish Rugby in terms of their coaches down there to get young people, particularly young males, talking about their own well-being, their mental health, and making sure that they've got a responsibility to take care of each other, and there's an opportunity to open up there, and also to train all of the coaches in terms of techniques to do that. So I'm just thinking sometimes it is looking externally out with the services that we provide in terms of health and social care to target those that don't even come to our site in the first instance.
You're dead right there, Fiona.
Yep. My next point is just in terms of the National Care Service, just the section that you did on the National Care Service. I'm really happy to see that children's services are included now, and that we're looking at justice-based services as well in terms of the impact of any national care service on that. So just in terms of future provision, I thought that was really helpful. And finally on this, that item 3 on the report, It's really just about the Health and Care Staff in Scotland Act and the need for us to consider and implement the impact on staff in there. And actually, while the kind of aspirations and everything are really good in terms of how we should be supporting our staff team, when we've got the recruitment difficulties that we've got, in terms of that, I didn't know how difficult it would be to meet the requirements that are put in place there. That was it. Sorry, like 3 in 1
Thank
there.
you. No, thank you for your contribution there, Fiona. That was excellent.
Thanks.
Christine, can I bring you in?
Yeah. Jennifer, John might want to come in around just the children and young people and mental health.
Yep, that's fine,
First.
John.
Thanks, Christine. Yeah, like Christine, the death of any individual to suicide obviously is tragedy. And Anne raised the issue of information about young people. We've got to be very careful about the information we put into the public domain about young people. Obviously, the numbers are very, very low. And the possibility of identifying young people through the publication of information. And that's why it's difficult to put out some of the information about ages, and the gender split's different because you're generally larger constituents. But normally when we've got numbers less than 5, we wouldn't publish that information because it can identify the individual concerned. So we need to be careful on that in terms of privacy and dignity and support to the families. Around the mental health service, Christine's absolutely right. The REN 10 is hosted by the local authority, but it's part of our partnership approach to services for children and young people. We actually have fairly significant input from the Health and Social Care Partnership to children's services through the work around the Choose Life strategy previously, around the Safe Talk, and the second course escapes me the title of it. It's just momentarily gone blank, but we've got lots of staff who are trained in those initial conversations. We have lots of information online. We have a school counselling programme that's available as well. So all of that in terms of the nature of resources and support to children and young people is robust. Now that doesn't mean we're complacent, Councillor Adam, because obviously there remain a number of young people who are distressed, and they display that distressed behaviour often through self-harm. The biggest challenge I think we face around suicide is that most individuals who complete suicide are not given us messages telling us that they're planning. They're not people who give you an early alert. Those people who give you an early alert actually are usually ones that we are able to intervene and offer support to. So the big challenge we face as services is how we make sure those people who are significantly distressed but are not reaching out and are not giving us obvious signs, how we intervene to support them. And Christine has established a local group that she's chairing around suicide prevention, and I think that's to be commended, and that hopefully we will find some additional solutions that actually reduces the impact of this very traumatic incidents for families and individuals across Renfrewshire. Thanks, Councillor Adam.
Thank you, John. Right, so
Jennifer,
Jacqueline. Yes.
Jennifer, can I just come in for Fiona's points around the Health and Care Staffing Scotland Act? So
Sure.
What we are doing, so that's not came into effect, and it doesn't come into effect until April next year. So we're in the planning phase at the moment across GG&C and the council. What I would say is we had our staff partnership forum last week, and we were commended for the work that we were doing within the HSCP around staff wellbeing. So, and that was highlighted as good practice. There was a range of things that heads of service had updated on. Fiona's absolutely right that when in a time where one, on the back of a pandemic, and the pressure that has brought, to where we are struggling at times to recruit and retain some staff, that staff wellbeing has never been as important. So we are there's a whole list of actions that we are taking to ensure that we're looking after that the staff who are in Renfrewshire and staff partnership, staff side, recognise that as good practice, and wanted to highlight that to the board. So it was just to mention that.
No, that's really positive to hear, Christine. Thank you for that. Jacqueline, you're next.
Thank you, Chair. I just wanted to say how delighted I am that John Goldie's become the independent chair of the Alcohol and Drug Partnership. Hi, John. Obviously, I was chair of the Alcohol and Drug Commission and worked with John, and we all know him well, so it just feels a very natural fit. So look forward to working with you again in the future, John. Thanks.
That's excellent. Thank you. Right, John Matthews, come on. Here you are, John.
Thanks, Jennifer. Just again for information, the members of the IJB will know that Glasgow IJB on Wednesday passed the proposal of setting up the safe consumption rooms, but also to say that I was at pains to say that it shouldn't be safe. We should watch our language. It should be safer, because it's never safe to inject, whether under supervision, as is the proposal in Glasgow. So that we're going to term, and hopefully that the language will change to safer.
Safer.
Thank you.
Thank you, John. Well, that's very important. Thanks for telling us. Fiona, you're next.
Hi, good morning, Chair. I think this conversation just highlights the real need for the carer centre.
Yep.
It's been a life-saving resource for many carers who've just been really low due to the impacts
Absolutely.
of caring. So I think this conversation highlights many people walking through that door for the first time are petrified and have had suicidal thoughts. So this is a very interesting conversation for carers.
Absolutely, Fiona. I don't doubt you're at the forefront of actually being able to identify lots of people that don't come to our services because they're virtually on the verge of breaking, with their caring roles when they come to you. So, the carer centre is such an asset. It really is for the population and for ourselves. So really, you do a great job. I know for myself, obviously I used to attend the carer centre after my stroke, and I know what a great job you do. So no, you're really well placed, Fiona, to be looking out for anybody that needs help, So, and that's the best thing. It's all through partnership, working and learning from each other, knowing what services are open to us, knowing where we can signpost people. As you say, Ren 10, I was thinking about Kick It On when Fiona was saying about the rugby, the Scottish rugby, to try and tackle people that aren't using services. I was thinking about football, and we've got that third sector organisation in Linwood that do a tremendous job to helping prevent suicide. So all of these things linking in, signposting. Brilliant, Fiona. So thank you very much. Right, so that takes us on, if there's no more questions, that takes us on to item 4, which is the financial report. Chief Financial Officer, so that's yourself, Sarah.
Okay, good morning, everyone. This is the first report for this financial year, and as expected and as we had thought in terms of the budget position, we are reporting a significant overspend at this position towards the year end. What I would like to highlight is, and it's in section 1.3 of the report, this doesn't include, the projection doesn't include the current pay offer. It's just based on the 3% that we built into the budget, because at the moment we don't know what the pay offer is going to be accepted for local government staff. But
Sure.
what I would say is, based on the current offer, it would be roughly £1 million in additional expenditure in relation to adult social care. So that's just to note, that's still in debate. And until we know what the outcome of that will be, we'll have to carry on reporting what we know at the moment. Also, just to draw the line that actually probably because of the past few years, the trajectory of normal spend is completely blown out of the water. So it's actually really difficult for us now in terms of care at home and care home placements, particularly to understand exactly what that pattern of spend is going to look like. So that at the moment it's based on the current position, but that may change over the winter. So the position is slightly better than we thought it would be at the moment, but that may well change going through the winter, as you would anticipate. Also want to highlight in 3.7, the large part of the underspend at the moment is due to employee costs. In fact, it's about 1.8 million, but some of that is due to incremental drift on health posts, and that's the way that we structured the budget over the years, and I discussed that at the development session, and it's something that we want to look at, because otherwise we'll continue to have an underlying underspend which could be used for other areas. Also, quite importantly, to if you look in section 5, we still do not have up-to-date information in terms of prescribing data. There's continues to be a problem with the new system that they're implementing. So that position may change. We're basing our information on April data, which isn't fully up to date, as I've said in there, and that can actually change volumes and prices, etc. So the position may be better, but it also may be a lot worse than what we're anticipating the spend is at the moment. And we continue to work with the Scottish Government, and particularly that part of the government, to NSS, to push this forward, but they are having huge problems in terms of pushing that data. Hopefully in the next month or so we'll have more information and a more accurate projection for everyone. And finally, in section 8, I've shown what the position is in terms of reserves and how they are going to be depleted over the next few years, especially in terms of the earmarked reserves. So that's just basically the finance report just now. It is slightly better than we had anticipated, but there's huge caveats on that I just wanted to draw everybody's attention to. So happy to take any questions.
Thanks for that, Sarah. I see Ian McMillan's got his hand up. Come on in, Ian.
Okay, thanks. I see you're obviously talking about the prescriptions still being an issue, and I know that's getting touched on later on in agenda, so I don't really want to go into that too much. But councils have heard recently about a probable windfall in terms of the employers' contributions to Strathclyde Pension Fund. Is that going to affect ourselves in the IGB and the staff in the NHS? Thanks.
So what it will do is it doesn't affect the health post, because it's just to do with Strathclyde Pension Fund. So we're currently working through what the impact of that would be. So that would be for 24, 25 and 25, 26. It would be a non-recurring reduction. And thereafter it's a reduction in the percentage, so that would then be a recurring reduction. We haven't yet had those discussions with the council on their understanding of what that position would mean, but my assumption would be that sits in our budget and we would be able to use that, the non-recurring element, to help shore up the overspend in the next couple of financial years. That would be the plan, and thereafter you would have a recurring and saving that we could make to offset some of the other pressures. So that would be the hope. We're working through what that might look like for us at the moment, and so hopefully that could be good news for us.
Thank you, Sarah, and thanks for that, Ian. Margaret.
Hi, thanks, Chair. Thanks, Sarah. Just a few questions, really. I'll just rattle through the questions, and then if you need me to expand, that might be easier. The prescribing issue, where does the issue lie there? Because that's just not acceptable in terms of the impact across the system, is it? To not know where the position is from April. So that's the first point. I realise it's not a local issue. The second point is on the pay negotiations. So depending on the outcome of that, will we once again end up waiting on how the council decide to flow through any uplift that might come through on that? So I'm just trying to understand what the IGB's position might be in that. And then I guess a wider question, given some of our neighbouring IGBs are now in financial recovery planning mode, can you just clarify for the IGB what the key trigger is to go into financial recovery planning? Is it when reserves are depleted, or at what point would that kick in? Thank you.
Okay. So first of all, the prescribing issue, it's to do with the new system that NSS are implementing, and they've had real issues with the actual system and the data, and there's a double count as well, so we can't, the data that they're releasing, the integrity isn't good, so they're working on that. My understanding is that they've actually taken on a lot more staff recently, so that should help push through all the backlog of data that's not been updated, in records that need to be, the transactions, the number of prescriptions, etc., that need to be processed. They're working on that, and you'll probably be more than painfully aware that they're getting a lot of pressure right across from both health boards and IJBs, because this position isn't sustainable for us, because we are really working in the dark on this. We're really hopeful that our information that we're using is as close as it can be, but until we have that data, there's not a lot we can do. They are under a lot of pressure to get this moving forward, so we continue to badger them almost daily. So, I mean, it's really out of our hands, I'm afraid. In terms of,
thanks, Sarah. It's just, I think we've just got lots and lots of examples recently where NSS isn't performing the role that we need it to. So
absolutely, it's very frustrating, but we continue to work with them as much as we can. And the second one was on pay negotiations. Yes, absolutely, we will be. It will be up to the council to decide how much of the uplift they pass forward to us. There is money available from the Scottish Government. It's not yet clear the full amount that's coming from the Scottish Government. It's a little bit complex. Initially it was 155 million, but my understanding is there's potentially a further 80 million, or it could be 90 million that could be coming to local government as well. So we await the council's decision on how much of that will come to us. And thirdly,
before we move on, can I just clarify, will there be any improvement on the clarification that will come from Scottish Government that councils should pass on money that is intended effectively for staff working in the partnership to flow that money through, unlike the situation we saw last year?
I think that's doubtful.
That's really unhelpful.
Yeah.
And I don't know, Chair, if there's something we can do to clarify that position, because this is really undermining how IJBs have to work in partnership.
No, I think we should schedule a meeting. Sarah, yourself and I can go in and meet with the council leader and head of finance and kind of get some reassurance when it comes to that, because that's what we need. We need reassurance that we're going to get a fair share passed down to us. So we'll schedule that and bring it back to the next meeting, Mags, for an update.
Thank you, Chair.
That would be helpful.
No worries.
And then the final question was on recovery planning. So for us, that's really our Sustainable Futures programme. So we've already kicked off our savings programme for next year and the year after. So there is no formal trigger for recovery. It's really up to each individual IJB how they manage that. But by necessity, we are almost in recovery anyway, and we're trying to manage all of our spend as best we can. So we are not. It's really, really difficult to say what would that trigger be. Well, we are already in an overspent position, and we'd agreed how we would manage that this year, and that would be from the use of general reserves and other reserves to help us manage the financial position. But going forward, our recovery is the Sustainable Futures programme, which makes it really, really important that we actually are able to take all of the areas of the programme forward. Hopefully that answers that. Mags?
Yeah, Chair, if it's okay for me to comment, thank you. I think that's helpful, just so that it's clear in my mind the language that we're talking about. So effectively we are in that recovery planning, but it's the Sustainable Futures. So it might be obvious to everyone, but I just wanted to make that clear in my own mind. Thank you.
No, it's helpful to make it clear in your mind, because sometimes, you know, we can forget ourselves. So no, thanks for your contribution there, Mags. So is there any other questions? No. So can we agree to note the in-year position as of the 31st of July 2023, and can we note the projected year-end position 23 and 24? So I agree that. That's agreed. So Sarah, I think you're up again for your IJB audited annual accounts.
I am indeed, and I've also Grace Scanlon's also here from Ernst & Young, and she'll make a couple of comments on the accounts. They were submitted for approval on the 30th of June originally, and then they were taken to the external audit for their review. And on the 18th of September, they were submitted to the audit committee, where they were approved. And it would be probably better for Grace to just do a very brief highlight of what that actually meant for us, rather than myself, if that's okay. I'll just hand over to Grace, and then after that, I would recommend that the accounts are approved for signature after this meeting. Thank you, Grace.
Thank you, Sarah.
Thank you, and good morning, everybody. I guess I just had a couple of short things I really wanted to highlight. The first is actually on the accounts themselves, and then secondly, I was going to talk a little bit about our report, although I don't think it's on the agenda for the board today. The first thing I suppose was to say that we're really pleased that, subject to your approval today, then we will be meeting the earlier audit deadline for this year, so we are back into a normal audit timetable, and I think that makes a big difference, particularly for the finance team, getting into budgeting, I suppose, and meeting some of those challenges. And yeah, I think it is about two months ahead of where we were last year. So I guess I think that's an accomplishment anyway, but particularly on the first year of an audit, because I mean 6 or 7 months ago we didn't know each other between the finance team and EY, and we do know that we've got a really different approach. We ask lots of different questions and we've got different systems. So I think it was a really tough ask, and my thanks really go to Sarah and the team for getting us here.
Yep.
I would also note that we noted at the audit committee that we consider the standard of the financial statements really compares well to other IJBs and others across the sector. I was going to just quickly touch on our report because it was, as Sarah said, scrutinised at the Audit Risk and Scrutiny Committee. But it was just to highlight that we use RAG ratings to be clear about our assessment of the risks that are impacting the board, and we use them particularly for the 4 areas of wider scope work that we cover as part of our wider responsibilities, which is on financial management, financial sustainability, vision, leadership and governance, and use of resources. We assessed all of those as green during the year, with the exception of financial sustainability, which really reflects, I think, as you've been hearing earlier, our concerns around about that projected impact of cost pressures this year and beyond. The other conclusion we're required to make every year is on best value. But in IJBs, that's very much based on the work that we've performed on those 4 wider scope areas. So in the version of the report that we presented to the committee, then we had assessed best value as amber, basically because 3 greens and a red doesn't equal a green, I suppose. But we did conclude within our report that performance management and financial reporting arrangements do allow the IJB to demonstrate the achievement of best value. And really, we reflected on the comments at the committee, in particular from the chair, and we had a rethink about that amber assessment. And so within the final version of our report that we intend to submit to Audit Scotland, then we're going to take out that amber rating. So it will just be that statement on best value that we think that your arrangements do allow you to demonstrate the achievement of best value. I think that we felt like we were kind of marking the IJB down twice for matters that are kind of beyond your control. So I think that that's all I wanted to bring to your attention this morning, but I'm happy to take any questions.
Well, listen, Grace, that was really helpful. Thank you very much for that contribution. Do we have any questions or comments about the annual accounts or about Mags? Oh, Jacqueline, your hand's up.
No, just to say to Grace, thanks for listening, particularly to what Max said. We appreciated that and appreciated that you went away and had a think about it. So thank you.
Absolutely. Right, no, that's really positive. Right, so if we're all agreed, then we can just approve the annual accounts for 22-23 and we'll prepare them for signature. The council should have my signature, okay, James, for you to submit that onto the paperwork. And then that takes us to item 6, which is the development of sustainable futures. So that is that you, Francis?
Yeah, it's me. Morning.
Good morning.
Okay, in June, the IJB approved proposals to create the Sustainable Futures programme. So this paper really just provides an update on the progress over the summer period since that meeting. I won't go through the full paper, but there's a number of key points that I just want to highlight this morning to members around our progress. Firstly, the implementation of governance arrangements, including the establishment of our programme and project boards to ensure appropriate oversight and control. So the programme board, which is now in place, is chaired by Christine, our Chief Officer, and we have representation from staff side, trade unions, HR and professional leads, and that board will be responsible for monitoring and tracking progress and responsibility for ensuring that the risks and issues that are identified are appropriately assessed and where possible mitigated, and this will provide, it's on the basis of this that we'll use it to provide assurance to the IJB. The paper also sets out the significant activity that's underway for each of the projects within the programme, the development of project charters, and also work to identify the sort of interdependencies and linkages between the projects. And I would say this work is
pretty complex, and the paper provides some examples where there will need to be a phased approach to delivery, recognising those interdependencies between some of the projects. We also highlight in the report the engagement work that's been undertaken. At this stage, the engagement work's principally about the overarching programme and raising awareness of this and the financial context in which the HSCP is operating in. And we've been linking in with a number of key stakeholders, including updates to the Staff Partnership Forum, with our own staff through various networks and channels, and critically with our strategic planning group and the network of care planning groups that we've got as well. This paper also seeks IGB approval to expand the current programme scope with 2 further opportunities identified as part of the programme set-up phase. So the first, as we've already mentioned as part of Sarah's report, is to carry out a review of practices and processes around prescribing that's within the control of our own HSCP, recognising that all of it is not within our local control. And this is with a view to making savings, or if not savings, at least cost avoidance, recognising that prescribing is one of our biggest cost pressures. The second area that we're proposing is a review of the health payroll budget setting process, with a view to identifying efficiencies, and Sarah touched upon the rationale for that as part of her update. So if they're approved, both of these areas would be incorporated into the savings and best value work strand, which is being led by Sarah as Chief Finance Officer. Finally, and really importantly, we would ask members just to note the key risks that are highlighted in section 8 of the report, recognising that if these risks materialise, they could impede the programme's ability to successfully address the budget gap as planned. So we just ask members to note these. So in terms of next steps, we'll look to bring an updated position to the IJB in November, which will reflect the associated development of saving proposals and also the phased approach that will be required to deliver this. So that's all I plan to cover. Really happy to take any questions. Thanks.
I see there's a few hands up here. You've just been the first on the button there, right, Ian? When you come.
Okay, thanks very much. No, I'm pleased to see the prescribing is kind of moved up the agenda. I think you lay people like myself know that there is a lot of wastage in the prescribing. You know, at the moment, as somebody who takes 2 pills every single day, a man of a certain age, I know there's lots of stuff going on that prescriptions are not reviewed. You just get your prescriptions. I've been in the same prescription for 20 years or whatever. I've been asked, do you still need them? Do you need to? That's absolutely right. The payroll thing is you know, is an intern thing, and that's of course that's how we should be looking to see if we can do things better and more efficient. But obviously, what's over the horizon with the 14.7 million gap is quite scary. I'm pleased what's going on. You know, particularly engaging with service users. That's really
Your signal's coming and going, Ian. I don't know if I'm the only one.
good.
Oh, you're back in the room.
All right. Am I back? I'm not very sure if I've been. I don't think I've been deliberately left in the dark, but I really don't know what's going on. And my fear is that I come to the November board, and there's a whole set of you know, proposals that I've only seen a few days before, and I've had very little discussion on them. So I'm a wee bit concerned about that. As I say, I'm pleased what's going on, but as a board member, I need to know exactly what's going on, and at this precise moment, I don't.
Sorry, Ian, see, it kind of went silent, and then you came back to say you feel as if you're in the dark. I kind of missed what you feel you've been left in the dark about. Was it I missed that?
Well, right, so sorry about that, because I'm in the same hotel as you, and it's not a very good reception.
That sounds a bit dodgy.
I know exactly. Not the same hotel room, I have to add. What I was saying is I'm pleased that the work's going on in the background, but it is in the background, and I feel as if as a board member, I'm not really sure what's going on, what's been proposed, what service users are saying about it. I'm not entirely sure. And as I said, I'm sorry if you've heard this before, I'm concerned that I turn up at the board meeting in November and there's all these proposals which I've only seen a few days before, and I'm not entirely sure what's going on, and I've been asked to agree, disagree, things I don't really know too much about.
I would hope to reassure you, that would never be the case. What's going to come forward is what we've been talking about over the last year. So there's going to be no nasty surprises, Ian, and I can say that. But I bring Frances in to reiterate that, but I'm sure of it, Ian. But Frances,
yeah. I guess, Ian, that I would echo what Councillor Adams said, but it was just to highlight the complexity of the work that we're carrying out just now is probably refining our thinking about what we can bring to the November board in terms of recommendations. We will be developing a range of options. However, it is likely that these options we would take to the November IJB meeting to get approved by the IJB to then engage more widely on. So at the moment, the work that we're doing is really just to collate the data that we require to inform options appraisals rather than having options appraisals ready at the moment. The work over the summer has taken a lot more work than we anticipated to ensure that we have, I guess, robust data to support anything that we would be taking to the IJB. But during this period, and as we refine those options, we will certainly be engaging with IJB members and with the care planning groups around these. However, at present, it would be more likely that we would bring a range of options to ensure that we have IJB support to proceed, and it may be the decision of the IJB that some of those options they'd wish to discount rather than us engaging more widely on all of those options. So I hope that provides reassurance, but certainly we would not be looking to bring any sort of final recommended proposals without adequate consultation with yourself and engagement with key stakeholders.
Thank you, Frances. Right, Fiona, I see you've got your hands up.
Yeah, thanks. I suppose my first question was initially just the same as Ian's, and what kind of form would these options take place? You know, yeah. How would they be presented to us? And obviously not just kind of finished options. That's kind of what I was hoping for. My second two are just kind of points from your report. And one of them is just in terms of the whole family support section that you covered. And it was really, from my perspective, that it was really good to see deliverables in terms of the promise and the fact that we need to take into account what the promise's aspirations are in terms of how we work with young people who are care experienced, the language that we use, the policy that we use. So it's lovely to see that and just to encourage that work to be ongoing. I have to declare here that I'm a promise keeper myself for the council, so just to let you know that. And the other point really was just to comment in terms of the housing contribution section, and it really was just I'm pleased to see that we're taking a nice focus on the transitions element, because I know that's incredibly difficult for young people that are moving from young people services to adult services. Yeah. And I have to be honest, I don't always think it's done very well. So it's really nice for us to have a look at how that's done, look at what I suppose IT solutions are there in terms of web-based work to help people through that really tricky process. So it was really good to see that in your paper. Thanks, Frances. That's it.
That's excellent, Fiona. Thank you. I totally agree. Jacqueline, you're next.
Thanks, Chair. Yeah, it was just the point in 8.2 that really we're faced with having to make decisions because we need to have financial sustainability, and that we're not any different from any other IGB in Scotland, or indeed any other council. everybody's facing these decisions, and obviously, you know, as Francis was saying, options will come before us, but just to say that it's not a comfortable position to be in. It's not one we would wish to be in, but you know, we have to think carefully, and we know that you know, to maintain that financial sustainability, something's got to give. So yeah, but it will be good to have, you know, plenty of time to mull it over. So just the point that Ian made as well, so thanks for that.
Appreciate that. Thank you, Jacqueline. And Mags, you'd like to come in?
Thanks, Chair. Thanks, Francis. It was really just to get a sense, and perhaps it will come in November, but the introduction talks about the proposals will contribute towards the cumulative gap next year of nearly 15 million. And I suppose what I don't have a sense of is, are we getting proposals that will significantly contribute to that? Or are we going to get a surprise that says, actually, we've got these savings proposals, but we're still way off? And I'm just a bit nervous that we're heading into November, and I don't know that. And I don't know how quickly, if the IJB approves the proposals, actually how quickly those savings can come to fruition. So I suppose it's just that nervousness in my perspective that probably echoing the comments, I don't really know where we're at, and we're nearly into October.
Yeah. Okay. I suppose the first point is I can't give that reassurance at the moment. However, there's 2 points of it to that. I guess the first point is the risk that we've highlighted within all our papers since the start of the Sustainable Futures programme, where we have highlighted that there is a risk that even if we have to deliver, or we deliver on all the areas that the IJB have approved, that there is still a risk that this will not be sufficient to address the full budget gap, and that is why we continue to have resource dedicated to looking at other opportunities and ways that we can address that gap. And an example of that is the paper today, bringing forward the 2 additional areas around prescribing and also the health budget, staff budget setting. The second point is that we will look to address the gap as far as possible. However, within the proposals that we would bring in November, there will be a range of options and a scale according, so that will be subject to the IJB's appetite to go forward with the sort of which options it will choose to take forward. So we couldn't at this point give you a figure for that, but there will be a range of options that will set out how we could address that 14 million.
Okay, Mags.
I think.
Are you okay?
She frozen. Yeah, sorry. Yeah, I think it's just, I still remain nervous. Thanks, Chair.
Yeah, it's understandable. I remember we had the discussion at Development Day that even with the savings, there could be a shortfall. We don't have a figure on that, so time will tell. Right, we have, I've got an update on my computer. Hold on, I'm not about to restart this. No. Right, Stephen is next.
Chair, John's got his hand up.
I think Stephen's first, but
all right, is he? Sorry.
According to my little list.
Thanks, Jennifer. Just 2 points really. On prescribing, as somebody that takes over 30 tablets a day, I'm happy to see that there's going to be a review of prescribing, because I would love to see myself taking a lot less.
Mm-hmm.
The second point being, on the savings, as a service user, obviously there are worries for other service users.
Yeah.
And I wouldn't like to see, obviously, people losing out in services. And I know that is a possibility. But obviously, I would be hoping that we can keep the loss of services to a minimum. Absolutely. For the sake of the people concerned, because these services are essential for a lot of people.
I know they are. You know, I do appreciate that, Stephen. I know it's really challenging, and let's hope we can do our best to protect all our frontline, you know, services. So, but time will tell. November will tell us a lot when we get the papers back and the proposals in front of us, Stephen, what we're looking at. And then we'll have a better idea, I suppose. I think that's why the nervousness is coming, because we're all sitting here thinking the next board, the next board, the next board. We're waiting for these, but obviously they've got to work up the kind of business proposals before they even bring them to us to test our appetite for them, Stephen. But no, I share your concerns. We all do, Stephen. We all do. Okay, right. So next we have John Matthews.
Thanks, Jennifer. I just wanted to say, at the development session, I heard Francis give assurances that nothing had been decided and wouldn't be decided until it was brought before us. Now, I also understand, and this meeting has expressed it, and you've done that yourself, Jennifer, the nervousness that is in between being assured that nothing has happened and will not happen until it's brought before us. And when is it going to be brought before us? And of course, Margaret has also said, you know, at some stage or another, do we run out of runway in you know, being able to bring the proposals and for them to be effective over the period of time? But I think it's good that we've been discussing that. I hope that's come over, that there is a tension between nothing being decided, but at the same time that these proposals will come to us in a timely way that will enable us to actually make the savings that we're proposing.
Absolutely, John. No, you're dead right. You've summed that up well. Right, and Anne, Cameron Burns, when you go.
Thank you, Jennifer. And then just get into the whole Cameron Burns. But my thoughts in regards to the prescribing, correct me if I'm wrong, but does not every GP practice have a designated pharmacist within their GP practice? They'll have it in other places, like well, my GP practice has a designated prescriber that would look at our prescriptions and then say, well, we can give them this generic one, we can give them this generic one, and we can change. So I thought that happened in all GP practices, but it doesn't in your area, or does it?
Well, it doesn't. My personal practice doesn't do it. I've been the same tablet for about 20 years since I had my stroke. It's never been reviewed, but I'll bring in Stuart Sutton. He's probably the best advisors in this, Anne.
Okay, thank you.
Sorry, I don't want to labour the point on prescriptions, because I know there's an awful lot to cover. Just to clarify, that there is an awful lot of work that goes on already, and a huge amount has been achieved in NHS GGC across the board in ensuring that we prescribe the most cost-effective medicines at a time that it's only appropriate or necessary to provide them to people who need them. So, you know, people will have been having their medication reviewed. It may have not been in person with a GP at every time, particularly during COVID, but certainly medication is reviewed on an annual basis. And, you know, we have to accept the majority of medication we start nowadays may well be required lifelong. It isn't often something that we can stop. That said, the area we are often focusing on is in people who are frail and very elderly, in which case often medication, when you're above a certain degree of frailty, there is often limited evidence that medication will be beneficial, and actually we look to deprescribe and focus on realistic medicine and quality of life wherever possible. As you know, and again, that is something that has been in train for many years. I think the situation with the prescribing is really about trying to focus on doing more of what we know works, and building on the work that's already been done. But we also have to acknowledge that there is an opportunity cost to people spending time focusing on reviewing individual patients' prescriptions for our 180,000 residents of Renfrewshire. That is a significant time, and at the same time we're asking people to have better access and treat urgent conditions, and all of these things unfortunately are competing for the same professionals' time. We do have a substantial pharmacotherapy team, which I'll cover in the presentation that I've got on the agenda later. We don't operate it in a way that every practice has a pharmacist who is there full time, because quite frankly we don't have the workforce for someone to be in every practice at all of our 28 practices full time. But what we do have is a hub that covers all 28 practices, and we have pharmacists who spend some time in each practice. So every practice will have a pharmacist spending some sessions each week in there, but again they'll be focusing on much broader things than purely highly cost saving. There'll be many of them are, highly expert qualified prescribers and run clinics such as diabetes clinic or heart failure clinics for patients as well. So it is a little bit complicated, but I don't want to underestimate the work that has been going on and continues to go on. If we look at formulary compliance on the agenda item on the scorecard coming up, we know that the vast majority of prescriptions are the most cost effective and appropriate medications that are recommended by the health board and signed and Scottish government. So it just wanted to clarify that.
Thank you, Stuart. You've always got very
thanks, Stuart.
Right. I'm just gonna say you always put us at ease. You always reassure us. Sure, I always like having you here to back us up with what's going on. So well done for that, Stuart. Right, John, your hand's up next.
Thanks, Jennifer. Stuart is too much of a gentleman and a diplomat to say that when suggestions for changes to a person's prescription are given, they have to agree to it.
Yeah.
The GP can't force that. And I know from my knowledge of the GP thing from the board, NHS board, and the other thing is that the person, in fairness, who's been asked that is nervous about saying, yes, I'll change to this other tablet because my condition has been stable for 20 years. I don't want to alter that. So there's a complexity in there that Stuart's far too polite to say, listen, people have to say yes to this.
You're dead right, because I take a generic tablet as a muscle relaxant after my stroke to control the rigidity. And I was convinced it's baclofen, but I was convinced that this certain brand of baclofen was the only one that really worked. And every time the chemist gave me a different brand, I'd go, oh dear, don't think this brand works. And it did work. But as you say, so that's something as simple as that I take. So you're dead right there. There's always that kind of, oh no, what I'm taking is working for me. Let's not rock the boat. So no, I absolutely agree with that, John. Sarah, your hand's up.
Yeah, it was just to reiterate really what Stuart was saying, but also the reason that we've included prescribing was because I felt this is one of the biggest risks to our budget is the pressure on prescribing. But our ability to deliver savings on prescribing is very, very limited, and it's for a number of reasons, one of which, some of which Stuart's already talked about. But another reason is that actually Greater Glasgow and Clyde is actually one of the best at actually delivering best value for money in terms of using the various different systems we've got, like Script Switch, which would highlight to a GP that actually if you use this drug rather than that drug, it's actually cheaper. So our ability to actually reduce spend is quite limited, but we felt we have to actually make sure that the IGB is fully aware that we're doing everything that we can to manage this budget and to deliver best value as much as we can. However, it's more likely that it will be cost avoidance rather than actual savings we'll be able to deliver. So it's really important the IGB is aware of that. Notwithstanding that, if any savings can be delivered, absolutely we will be. But in addition to our own programme, prescribing programme, we're also part of the GGC-wide programme where we're looking at other initiatives, anything possible that we can do to reduce the pressure on this budget. So it was just to highlight that it's actually a really complex area, and our ability, as you would be more than aware, to reduce cost and volume is very, very limited. So it was just to highlight that to everybody as well, if that's okay.
Thanks, Sarah. I appreciate that. I know we've spoken about it before, the cost of the pharmaceutical companies, and the fact the problem is that there's no regulation there. So when you explain how much the costs have went up from £1.50 to £70, I mean, it's just astronomical. You just can hardly get your head around that there can be that type of increase. So no, I appreciate that, Sarah. Thank you very much. So if there's no more questions or comments on item 6, we'll just agree the recommendations if everybody's on board. So that's to note the update provided and the progress made in the implementations, the sustainable futures. The next one is to note the key programme risks set out in section 8, which we discussed. And the last one is to approve the proposed additions to the scope of the programme set out in section 7, which we have done. So we have agreed that. So we'll move on to item 7 on the agenda, which is the strategic plan, year 2 strategic delivery plan. And I believe that's David Fogg. David, where are you?
It is. Thanks very much. Hopefully I'll come up on screen now I've spoken.
I see.
So this paper follows on from the annual performance report, which the IGB considered in June and covered actions from year 1 of the strategic plan. and it provides an overview for members of the actions and deliverables which we've developed now for year 2. I think the most important thing to note is that over the last 18 months, the timings for planning have moved out of sync with the full year periods of the strategic plan, which runs from April to March each year. So to bring those back into alignment, this year 2 plan effectively covers the next 6 months to the end of March 2024. The paper itself provides a summary of how we've developed the deliverables set out in Appendix 1, noting that we have carried forward some actions which we started in year 1 and which are still ongoing, and we've changed a number of objectives as well to reflect the changing context. And an example of this, as we've discussed on that previous paper, is really around the significant focus that we'll have on sustainable futures, rather than the previously referred to transformation programme, which we had intended to put into place.
Sure.
We've also strengthened a number of statements where we're now, and that includes the example where we've identified 3 specific deliverables to help ensure that the HSCP supports Renfrewshire's commitment to delivering the promise. And we've also removed some objectives which were in the original strategic plan but are no longer appropriate. So, for example, we've removed specific deliverables related to and objectives related to the development of CAMS in Renfrewshire, noting, as we'd kind of discussed previously in the meeting, that that is now managed by East Dunbartonshire, the HSCP. One last point that I would just like to flag for members is section 7 of the paper, which provides a perspective that whilst we as a management team within the HSCP are confident that the ambitions set out in the strategic plan remain right for us over the next number of years, the ongoing pressures that we're facing around service provision and also the resource that we're going to be directing towards sustainable futures means that there might be a knock-on impact for us in terms of the ability to deliver all of the objectives that were set out in the 3-year lifespan of the strategic plan. So that's something that we're continuing to monitor, and we'll bring back updates on year 3 to the IGB in March, and updates on a view as to what we think will be achieved in that final 12 months of the current lifespan of the plan. And we'll also provide a view as to whether or not we think it's appropriate to potentially extend the plan into future years, reflecting the fact that we think the overall themes and objectives are still relevant, rather than looking to develop a new strategic plan for 2025. But very happy to take any questions from members.
Okay, thanks for that, David. Oh, hands are going up. Jacqueline, come on in.
Yeah, not a question, just it's good to see all the work that's going on and all the partnership work that's going on. And just to clarify, we're all in the same hotel because we were at the COSLA conference, and last night we had the COSLA Excellence Awards, and it was just great to see all the work that's going on across councils and HSCPs, and it just shows that doing things differently doesn't have to mean less. It can just be a way of being more creative with the money that you've got, and you know, just the excellent outcomes that we see, and last night really showcased that. So it was good to see that, and it's just good to see all the work that's going on generally. So thanks for the report, David.
Absolutely, Jacqueline. You're right. You know, everybody fears change because it's the norm, isn't it? But when you actually see what can be done, like some of the presentations last night, what they've done with such little budgets, you know, transformative for their area. So we'll bring a few ideas back to Renfrewshire. Right, John, if you want to come in.
Yeah, in these discussions, it's so easy to be, you know, downbeat about all the cuts, and why not? That's responsible and reasonable. I sit in the Glasgow IJB, and it's £21 million worth of cuts, and you know and they increase in the sense that they just don't stay there. Unfortunately, negative things get more negative. But what is exciting, and Jacqueline's highlighting it, and I try to do that too, is to say, even though we're in a position of cuts, there are things that need to be initiated, new things, and there are things that are existing that need to be expanded because they're so successful. And so it's to remind ourselves of that whilst there's cuts on the one side, there needs to be opportunities to increase the budget on the other side. And Jacqueline suggesting, I wasn't there last night, but suggesting that there are exciting things being talked about that are about what we are presently doing and are going to continue to do, as well as the things that make us feel so gloomy about the things that are going to be cut.
Thank you, John. They're right. John Trainer, your hands up.
Thanks, Chair. Actually, I don't want to say anything about the particular report, but it was just Councillor Cameron sparked an issue for me that when she said that a number of you were at the COSLA event yesterday, and of course locally we had a nomination in one of the awards, I Am Me, the local charity, who was supported both by Health and Social Care Partnership and Children's Services to develop an education pack, actually won the award in the section that they were in. And that's an education pack around alcohol and drugs. It's a very unique resource because it takes children through a life journey. And you know, the early years centres are able to access training material and discussion material to follow Zach. And again, I'm having another one of those senior moments, can't remember the second name. But there are two children. Was it?
Ella's the name.
Ella, so it is Zach and Ella, and it actually takes Zach and Ella from the early years, and it looks at, you know, issues about safety and how decisions are made. It takes them through primary school, secondary school, into adolescence. It is an absolutely incredible piece of work, and it was supported, as I say, by this Health and Social Care Partnership and by the Council's Children's Services. So we are talking about doing things differently. We're talking about preventative work, and that does take time to sometimes come through. But for me, this was a unique piece of work, and the fact that it did win the award last night was recognised nationally, and that resource has been used widely now across Scotland. It's a free resource. We, because of the funding this partnership and the council put in and the work of I Am Me, this resource can be accessed by schools throughout Scotland. So that's again about how we share good practice. So whilst there are some significant challenges for us as we move forward to look at how do we make sure services are provided safely, here's a good piece of work that this partnership's been involved in. Thanks, Councillor Adam.
Absolutely. And the children were instrumental in actually establishing it, you know, and directing it. So no, it was really, really, really good to see, Jordan. And as you say, it shows us different ways of working, you know. I think the pandemic has shown us that as well, hasn't it? Different ways of working. So absolutely. Jacqueline, your hand's up.
Yeah, no, I just wanted to say, I was going to mention it, but I wasn't sure whether HSCP had been involved, and always try and keep everything separate. So I'm glad that John brought that up. But yeah, Fiona was absolutely delighted to get the award last night, and myself, Jennifer and Ian were really chuffed for them. It was fantastic to see something positive.
Absolutely, definitely. Right, if there's no other questions or comments on item 7, then can we just agree the recommendations to note the progress, note the challenges, and approve the contents of the strategic delivery plan? Agreed? I'll take your silence as agreed. Right, so that takes us on to item 8, the performance scorecard. So is that yourself, Frances?
Yeah, that's me again. Thanks.
That's okay.
Okay. So this paper presents the proposed performance scorecard for 23-24 for IJB approval. The full scorecard can be found in the appendix. The scorecard's a similar layout to what the IJB have had in previous years, with just a small addition of us now aligning all the indicators to the 5 themes in our strategic plan. However, there are quite a number of proposed changes to the actual indicators and the targets within the scorecard. So over the last year, we've had a dedicated working group that have carried out a full review of all the indicators, and a particular focus has been on our social care indicators, where we were keen to ensure that we had a more reflective sort of suite of indicators to show the breadth of activity that we're doing, but also overall just to ensure that the indicators that we're using are meaningful measures and continue to test our thinking around that. Where possible, however, we're trying to use statutory data that we're routinely reporting to the Scottish Government, because this has always been reviewed by our services anyway, and it's much easier for us to obtain through existing operational reports. So it's just making best use of our capacity. We've also, as part of this work, reviewed our targets, and part of this is we've had to take cognizance of the demand pressures we're facing, the staffing challenges we have, and the financial pressures, where we need to deliver on the Sustainable Futures programme while continuing to, I guess, keep the lights on and deliver strong performance. So the ambition is to have a sort of stretch targets, but ensure that they remain realistic. And for some areas, that might mean maintaining current performance is even quite challenging. So it's just to highlight that to members. So full details of the proposed changes and the rationale for those can be found in Appendix 2 and 3. But they are summarised in the cover paper. So we've highlighted those, for example, that we've removed. And examples of that are those relating to CAMHS and paediatric speech and language therapy, as now they are hosted. However, just for members' reassurance, we know these are areas from previous performance reports of great interest to members, so we will continue to still monitor these, and we're happy to provide regular updates on the local position as required to members. We've also highlighted where we have amended the targets, reflecting the point I mentioned about ensuring it's realistic but stretch, and where we've amended indicators, either the wording or the definition of these from previous years. And then finally, we've provided the detail on the new indicators that we are proposing to include. One thing that members will know is that there's less targets in the report than previous reports, and that's because where we have completely new indicators, then in some areas we won't have enough information previously gathered to set targets, because we'll need at least 2 years data to be able to sort of have a baseline and to inform the targets that we'd look to set. So that's something over the next year as a sort of transition year we'll be able to develop targets on. So really, subject to approval today, we would bring a full mid-year scorecard in January, and then the end of year update as part of our annual performance report in June. We are also at the moment subject to an audit of our performance framework. So once the findings of that are available, they'll be reported through the Audit Risk and Scrutiny Committee. However, we will reflect any of the recommended changes within any future reports to this IJB as well. So happy to take any questions. Thanks.
Thanks for that, Frances. What was I going to say there? I know that I had a conversation with Christine at the pre-agenda. I appreciate that CAMHS are going over to Eastern Bartonshire now, but I do think it'd be helpful, Christine agreed, if maybe quarterly or every now and then we could bring a report back, just so we don't lose sight of how well CAMHS have done, the change that they've made, and our speech and language therapy, because obviously we noticed, we already showed concerns that there'd been a reduction, and I see that's dropped again. So if we can just, Christine's already agreed to it, but I think as a board it would be helpful for us not to lose sight of that. And I'll bring in Fiona.
Thanks very much, Jennifer. First comment, really is great to see the increase in the number of adult carer support plans that have been undertaken through the carer service. That's great, and given what was said earlier about how desperate they are when they come to the service, I think it's really good that that's happening. So well done, I have to say, to that service. Just a query in terms of that. So there's more adult carer support plans being undertaken by the carer service, but less by the HSCP. Is that because our direction is to in the main, have most of them undertaken by the carer service? And my second question just is in terms of the indicator around about alcohol and drug waiting times on, I think it's page 185, at number 12, performance indicator. We've just got alcohol and drug waiting times for referral to treatment percentage seen within 3 weeks. And I can see that the percentage is there, but I wanted to know how does that align with the MAT standards, the current MAT standards just now, and the kind of aspirations in terms of treatment there. Thanks.
Okay, thanks, Fiona. I'll bring in Christine, I think. Is Christine, do you want to answer that? Is that how you get your hands up?
Just in terms of the drug waiting times, Fiona, so you saw from that paper that our performance was below the target of 90% of that's referral to treatment within 3 weeks, which is is the Scottish Government target. We are now, our current performance right at this minute is 96%, so we're exceeding it. So we did have a bit of a blip, and that was around staffing and also sub-recording, because we had moved over to, well, the whole of Scotland had moved over to a new recording system, and it just took a little bit of time for our staff and our teams to get used to that. So I'm pleased to say that we're back on track and we're exceeding that. In terms of our MAT standards, we're also in a very good position. So one of the MAT standards is around access to treatment in terms of medication-assisted treatment on the day, and we are absolutely moving forward to be able to deliver that in most cases, but that is a challenge for all services, and it very much depends on staffing and what is required. So we are, I think we're in a good position. Donna is coming in later on in terms of our ADP coordinator, and will give us a bit of detail around our ADP and performance and the submission back to Scottish Government. But certainly Renfrewshire was in a very good position of late, and that was recognised by the Minister when we met with her around our MAT standards and where we were in green. I can't remember off the top of my head in terms of how many green indicators, but we were mostly green with a couple of ambers that we were working on. So there was no great concern raised from the Minister in terms of the progress that we were making in Renfrewshire. So hope that gives you some assurance.
And with regards to Fiona's first question, with regards to the care package referrals, Francis?
Yeah, I may bring in Lisa Cameron's on the call, and she may wish to add to it. We haven't routinely reported on the HSCP figures before. It's always just been the carer centre. So this is part of the improvements to this scorecard. So there is some work to ensure that we are actually not under-reporting, and that there's a robustness within the locality services about how this has been recording. But Lisa, I don't know if you wish to add more about the work that we're doing.
Yeah, obviously we've changed over to new systems and Eclipse systems and things like that, so we're constantly improving it. Whereas the data is coming out, we're seeing where our shortfalls are, where our improvements are. We've just done a number there with our self-directed support, ensuring that we're very clear where options are, where people have been given choice, where they've been given control. Because before, a lot of things were maybe getting taken for granted, that the worker was having that conversation, but it wasn't getting documented. We also, the same with our carers assessments and so forth, a lot of the carers assessments at that time when we were doing the carers assessments, people are then saying, well, I just need the care forwards package in, and I'm not worried about it because I'm not getting in. If they look after them, they're fine. So we're kind of looking at that and thinking, well, is it because of the length of our assessment? Is it the time that it's taken for people? Do we do the immediate work so that that carer then feels as if they've now got the time to sit down and go through assessment? So we are looking and constantly looking. We have a team set up with our data team, and then set up with the localities and set up the carers group. So we're bringing things constantly back and updating that in the hope that the data we are getting and we are providing is more accurate. We're even, as Francis is saying, we're meeting regularly to say, well, what figures, not just what the Scottish Government needs, what do we need? What do we need to understand our service? What do we need to understand our community? So yeah, the systems are getting updated, the processes, and hopefully the data comes out of that will help to improve the services moving forward. I don't know if that answers the question, or if there's anything specific you would like to ask.
No, that's really helpful. It was just, I was aware just in terms of how it was reported and seen that there was a drop, and I just wondered if there was a direction that was taken us towards nearly all of that work being undertaken by the care service. Thanks.
Okay, that's great. So there's no more questions. We'll just move to agree the recommendations, which are to approve the HSCP's draft performance scorecard for 23-24, and to note the full scorecard updating all performance measures will be presented twice yearly, mid-year in January 2024, and at the end of the year in June 2024 as part of the annual performance report. Okay, so we agree those recommendations?
Agreed.
Well done, Jacqueline, thank you. And that takes us on to item 9, which is quality care and professional governance. And I believe this is Pauline Robbie's first meeting. Welcome, Pauline. Pauline takes over from Jackie Diggle. So
yes.
Where are you, Pauline? There you are.
I'm here,
so,
I'm here. Okay.
There you go, Pauline.
Thanks, Councillor Adams. So, yeah, this paper I'm presenting has obviously been written by Jackie, so I hope I do it justice and able to answer any questions that anybody has. So as Jennifer says, this is the report on Renfrewshire's quality and care and professional governance from April 22 to March 23. And it's the purpose of the paper to provide assurance to the IGB of the work undertaken by the HSCP over that time frame, and to ensure that all services are delivered in a way that meets Scottish Government's quality objectives. And those are the safe, person-centred, effective, timely and efficient way of delivering. The paper gives a lot of evidence on how this has been achieved over this time frame, and also describes the governance framework that's in place to gain oversight and provide assurance to us all that we are actually achieving what we aim to achieve. I think it's important to note that the governance framework is dynamic and responsive within the partnership, and that's not only to ensure oversight, but to provide those conditions and culture necessary to empower our staff to notify of any issues, and subsequently we're able to drive those improvements. And that allows us to have a very open and honest conversation across all levels of the partnership, and to drive that safety culture of a learning organisation. And I think it's prudent to mention that just this week we received a letter from Scottish Government from Michael Matheson inviting all of us to review our governance arrangements in light of the outcome of the Letby case and some of the horrors that we've seen through that, and to really look at making sure that all incidents and any kind of whistleblowings have got a structure to come through and people are able to raise those effectively. So that certainly will be work moving forward that we'll be very keen to complete. So members will have read the paper, but I just thought it would be useful to highlight a number of what I feel is probably key areas. So in section 3, which is it follows from page 195 in the pack, that details our approach around safety and incident reporting management, the investigations and improvements, all of which are important to embedding that learning culture that I've been speaking about. And within that section, you can see a range of incidents and categories that have been reported and investigated, and you'll note that there's an increasing trend within the highest category, which is the one of violence and aggression. Now, positively, that could be related to much better reporting, which is absolutely good to see, but it's a concerning trend. And as such, the significant work has happened across both partner organisations and the HSCP around helping staff to reduce these incidents and manage these incidents and keep everybody as resilient and safe as we possibly can. Of the total incidents, there were 16 serious adverse event reviews that were generated, and these are incidents that either could or did have a significant impact, and there is a potential for widening learning not only within the HSCP but across the wider organisations. So the outcome and any learning from these types of investigations are absolutely shared across our governance structure locally and across the wider structure of the two partners organisations, and that includes the professional structures. And really what we're looking for is shared learning and implementation of improvement work across the system, with the aim of mitigating these types of incidents occurring again. And in the time for the report, I think it's important to note that our in-person contract management visits have now been reinstated post-COVID. So these strengthen our oversight of our commission services and help with the achievement of our governance objectives across our wider services. Additionally, we've provided some detail of note from our public protection activity in section 6, which is on page 200. And you'll note that there's been an increase in ASP referrals, adult support and protection referrals, from the previous year. Now, again, this could potentially explained not only by multiple referrals relating to the same individual made by different agencies, but an increase in awareness through the release of the Adult Support and Protection Code of Practice in 2022 and national campaigns. So positively, this reflects that services are recognising and responding appropriately to concerns noted to allow that gathering information and working to provide further support. And I think, and additionally, even though there's been an increase in referrals, the ones progressing to investigation have remained the same, remained static during that time period. Child protection obviously remains at the forefront of all our services, adult and children's services. And at the end of March, we note that there's 80 children that are on the child protection register, all with very individual plans specific to their own needs. And the HSCP continues to liaise with partner agencies to improve our practices from multi-agency learning reviews. And in this period, there has been one learning review report with all agencies engaged in addressing any actions identified and embedding them into practice. And lastly, I would just like to draw everybody's attention to the end of the report around the patient experience section, which provides details not only on some of the complaints and themes of complaints that we've received, and give assurances that they've been investigated and responded within timeframes, but also the compliments that we receive, because there is some incredibly good work that happens across the partnership, and from the governance structure, it's important to recognise and celebrate that, as well as have a very strong and robust process of investigating when things don't go as well. So I'm happy to take any questions if anybody's got any questions or comments on the report. Thanks.
Well, thank you for that, Pauline. Thanks for a very comprehensive report there. I don't see any hands up, but don't take that personally, because that's a testament to how good your report is. Oh, hang on, Lisa's got a hand up. Lisa, if you want to come in.
I was just going to come in with the back of Pauline. It says, well, the adult protection referral numbers have gone in, investigations remain the same. I just wanted to reassure the board that there's a lot done at the early stages in investigations, and there's a lot of work done to try and stabilise so that we don't have to go to investigation where we don't have to. It's about making sure we're working with adults, that the rights of the adults is taken into consideration, safeguards are put in place. So a lot of work continues under a care like kind of supporting people. Care management work is done to support people without necessarily having to go to adult protection, changing liberties and things like that. So it's absolutely right that we do that. So it's just to reassure the board from that perspective.
Thank you, Lisa. That's helpful. Anne. Cameron Burns.
I knew you were going to do that. This is a really good report. I was really interested in it. About the datexes that we're getting filled. Can I ask, what encouragement are we making sure that staff fill in datex? Because I know just through out and about speaking to staff, it's usually a time factor of filling them in. So how accurate are our datex reporting there, Pauline?
Thanks, Anne. I think that's a really relevant question. I think through all our governance structures, health and safety, as well as our locality governance teams, which a lot of the managers are represented on, we do discuss, that very open culture. If people are noticing things, we want it to be recorded. If it's a brief comment and with a coffee, we're making sure that people are, like, we really need to datex that, we need to hear about that, we need to be able to investigate that, and we need to have a robust way of documenting that investigation as well, and so we can share that learning. And I think as well, bringing to the groups, but within all the governance forum, the learning that we've got of some of the incidents, and giving those case studies back, and that learning really helps with that feeling that things are happening. When we do report, it's not just a report for the sake of doing it. We're actually looking at it. We're bringing back the learning from it, and we're making some improvements, and engaging the staff at the front line with those improvements is incredibly important. And that's part of what I said about that dynamic structure, being able to have these discussions and then take it back to staff. I hope that helps.
Thanks.
I mean, I'm sure there's, sorry, Chair, I'm sure there's things that we are missing, but it's that constant messaging that we want to keep very alive within our organisation.
Absolutely.
Yeah, I think for me, we need to remember that the datex is there for the near misses. So the near misses help us how we can not have incidents. That's fine. Thank you, Pauline, for that information.
You're welcome.
Thanks, Anne. Fiona, I see your hands up.
Thanks very much. I wasn't going to ask, but it was just kind of following on something that Lisa had said. And in the report, you mentioned that there had been an increase in terms of the adult protection referrals. And I do think probably some of that's about education and people understanding where to pick up there are concerns. But I suppose my question in terms of kind of follow on is, what is the process that we go through, or what work do we go through when the referral comes in and the assessment is that it doesn't meet the 3-point test?
what happens next. Is that what
Yes,
you're asking? I mean, Lisa will jump in at any point here, but certainly we'll be looking at a care management approach of that, Fiona. Do you know, so it's not just that it doesn't meet, therefore nothing happens. It's what else can we do to support that individual, and that's through care management.
Fiona, just to come in there's a very robust approach for adult support and protection. So if somebody's not open to anyone in an adult support protection, be it from a care home, from a police, from a GP, member of the community, the public, council, anything like that comes in, it comes through our early response and assessment system. So we've got social workers, occupational therapists and adult service coordinators who sit in duty every day, 9:15 to 5:15, and our primary response is to deal with adult protection. So they'll come in, and as soon as they're coming in within a couple of hours, their person's contacted, the information's gathered, we look in the system, we look at where the referrals come from. So there's a very robust approach to that. Also from it is considered, you know, often it could be that, you know, for instance, within a care home, two elderly people have kind of bumped each other, and that comes through, and you would make sure the care home's got the appropriate actions in place, appropriate safeguards in place, and you would downscale that appropriately with the safeguards. For other ones, it may be that the person doesn't meet the 3-point test, but actually does need some support, does need some help. Again, we're very fortunate in the facilities that we've got just now that we can allocate that very quickly to a social worker, to an adult service coordinator who works with the family, makes contact, goes out and visits a visit, does a full assessment. We're very, very fortunate in the robust systems that we've got within the HSCP, and if they're already open to somebody, they'll go to that specific team and that specific person who'd pick up. Sorry, you could get me on all day about this. This is my bread and butter, as you can tell.
That's really helpful. Thanks very much, and reassuring. Thank you.
Thank you.
Okay, if that's us, can we agree the recommendations on item 9 then? So it's just noting the contents of the report, noting the examples included in the report. Okay.
Agreed.
So that's well done. Right, so that takes us on to item 10, which is the Primary Care Improvement Plan, and that's by our very favourite clinical director, Stuart Sutton. Where is he?
Thank you, Chair. Luckily, I am the only, so I must be the best and the worst. Thanks for sharing the screen, James. That's really helpful. Okay. I'm not sure if you can make those slightly bigger, James, in the slideshow format. That's great. Thanks ever so much. Okay, so thanks everybody. I propose, if it's okay, just I've got 8 slides to cover, so I'll just rattle through if that's all right, and then I'd like to leave some time for questions at the end, because I think that's probably, the discussion is often really helpful. So in terms of the background, colleagues will know we've been working on this for now must be sort of 5 years. 2018 new GP contract. Effectively, it was a process of reform looking to make general practice more sustainable in Scotland long term. It was looking at reducing pressure, risk, and sort of repatriating some services to be provided directly by HSCPs and health boards. In terms of Renfrewshire's position, just to give you the scale, the HSCP budget of the NRAC share nationally is 5.75 million, and additionally we had that's additional to the 19.5 nationally that's provided for the pay uplift. If we go on to the next slide, if that's okay. Thanks, James. So in Renfrewshire, we made some very good progress. We met the requirements of delivery of the GP contract at the start of the financial year. So all 28 practices have access to each of the MOU commitments, the areas that were stipulated in the new contract by the BMA and the government. That includes the vaccination transformation programme. That means effectively that vaccines are delivered by HSCP and health board teams now. Community treatment and care services, which we'll come on to discuss in a little bit later in the presentation. Pharmacotherapy services. So this is what we touched on earlier. So we have set up in Renfrewshire a pharmacy hub, or a pharmacotherapy hub, which includes a multi-professional team of pharmacy colleagues, support workers, technicians, and fully qualified pharmacists, many of whom are independent prescribers. They work in a hub and they support all of the practices across Renfrewshire with processes like acute prescription requests, special prescription requests, looking at medicines reconciliation, so people who've come out of hospital, making sure that the medication is appropriately updated, and changes to people's medication recommended by consultants following an outpatient clinic. Additionally, the pharmacists who are working in practice will be doing what we call level 2 and level 3 work, which is, as we've talked about, kind of running clinics, doing some of that work on trying to deal with polypharmacy and support people to ensure they're on the correct and most appropriate medication. Link workers are aligned to every GP practice, and and that continues. We have urgent care services in place. In Renfrewshire, we mainly took an approach of going for advanced nurse practitioners and providing services to care homes. I think that's been a hugely successful service, and we have both a sort of proactive and a reactive service. So the care home A&P team have scheduled visits to care homes to review patients for whom any of the care staff have concerns or feel would benefit from a highly qualified clinical review, but also responding to individuals who may be presenting as unwell and needing a review on any given day. We've got an MSK physio resource. This is the only resource that isn't aligned to all 28 practices, and that's purely because of budget and capacity. So unfortunately, we were able to roll that out to 14 practices, but we simply haven't had the ability to roll that out further. But that is the only element of inequity that we've been left with at the end of the implementation. In terms of staffing, just to sort of show you, we've gone from having none of these staff employed by the HSEP in 2018 to having 120 whole-time equivalent staff supporting our 28 practices. So it is a significant workforce, and I think has been very successful. If we could move on to the next page, if that's okay. So community treatment and care services, this was one of the key planks of the 2018 contract. This basically means that many of the processes and investigations, interventions that might have been delivered in a practice by a practice nurse are now delivered by the health board in treatment rooms effectively. So the areas this covers would be things like phlebotomy, blood pressure monitoring, testing urine, measuring height, weight, body mass index, wound management, removal of sutures, injections. I've just put examples of some injections in there, but there will be others beyond that. Catheterization and management of leg ulcers, so that will be kind of significant dressings, etc. This is for all patients over the age of 16. Again, the message from the government and from the BMA around that was actually to free up practice nurse time to undertake a lot more of the chronic disease management that they were not able to perform because they were undertaking some of these interventions. So again, it was about upskilling and supporting the development of the generalist role of practice nurses, allied health professionals, as well as GPs. So I'll move on to the next slide, if that's all right. So in terms of the CTAC services, first thing to mention is phlebotomy is actually a practice-based service. So we have sufficient capacity amongst our phlebotomists to have one based in every one of our 28 practices. They're not there 5 days a week, but they will be there, pro rata depending on the size of the practice. And they are the colleagues who will be taking blood tests, undertaking blood pressure monitoring, for example, for people who maybe have hypertension, high blood pressure, or being investigated for that. They'll undertake urinalysis, height and weight, and measurements that form part of a subsequent annual health review for people with chronic diseases. The wider treatment room services, that's for everything beyond that. So that's for the things we talked about, like IM injections, wound management, dressings. These are all undertaken by our qualified nurses, and these are based within treatment rooms that are kind of broadly aligned to localities, but also where we currently have managed to secure capacity within our health centre estate. So we've got the list there. So we've got Bishopton Erskine, we've got a number in Paisley, Johnston, Linwood, Renfrew and Lochwinnock. We'll go on to the next slide, if that's okay, James. So in terms of the challenges that have been raised by colleagues at the IJB, as well as some patients, I think the centralisation of the treatment room services for residents in Bridge of Weir and Houston, for those who have found it more difficult to travel or are less able to travel, it has been highlighted that's been a difficulty for some people. Whilst we initially had some services operated from Strathgrive Surgery in Bridge of Weir, this was not HSCP accommodation. Unfortunately, as we kind of came out of COVID and demands on the practice crew, they required every room in the building for their own clinical staff, so we weren't able to continue offering it from that site. The HSCP, we are looking at alternative options to provide care close to home for those less able to travel. We're looking at a mobile or visiting service. This obviously will depend on funding and staffing resource available, but we're kind of in advanced negotiations with colleagues in the health board to try and secure that if we possibly can. And in the meantime, for residents on an individual basis who are unable to travel to treatment rooms in Linwood from Bridge of Weir or indeed Houston, there will be liaison with those residents on an individual basis where it's necessary, because we acknowledge there may be some some people who fall somewhere between being housebound and obviously requiring domiciliary services from our district nursing teams, and potentially being, you know, unable to make that journey into Linwood. You know, we estimate the majority of people, and hopefully many people will be able to do so, but obviously there will be some people for whom that won't be practical. If we can move on to the next slide, if that's okay. So in terms of what's next, so we're looking at the intervention list within CTAC, and we're going to extend that to ear care, which wax is something that people get very understandably interested in, and people want to know that they can get their ears irrigated or have microsuction for this. So that is something that is in the pipeline. We have staff trained up and equipment in place. We're looking at different platforms for feedback from patients, and we're looking at promoting the single point of access self-referral for removal of sutures and wound care. We've been liaising with the REH to make sure they're aware that of where they should signpost people and refer people now for that kind of post-operative follow-up, or people they've seen, for example, in ED and have had sutures. We're looking to increase the choice. So patients, basically, if you could potentially attend somewhere that is nearer to your workplace than your home. So we're looking at kind of opening up the range of treatment rooms we've now that we've got every treatment room up and running and all 28 practices covered. And again, we're working with the government on the PCIP tracker, because I think we've acknowledged, and we've talked about this before, and every IJB has recognised that to deliver a full deployment of the GP contract that would cover, particularly for us around pharmacotherapy, is the element that we've probably achieved a lot, but not quite reached the point that we would like to achieve. That would require additional funding than we've currently got at present. I'm just going to touch on general practice more widely, very briefly, on the next slide. If that's okay, James, thank you. So, you know, this won't come as a surprise to anybody. You know, it's in the national news. It's something that I'm sure people may have experienced themselves, or may have had raised them. You know, GP practices are under significant pressure, and we can't make any bones about that. That is the situation we're in. There's a serious challenge nationally regarding GP recruitment and retention, and again, there's a high level of demand within general practice. You know, and this exacerbates access issues in primary care. It's important to acknowledge, as I've said on there, the understandable impact of delays and pressures in other parts of the NHS. So, you know, with our acute colleagues working incredibly hard to try and reduce some of those really long waiting times that have occurred as a result of COVID. Understandably, people present to their GP and indeed A&E and other parts of the health system multiple times in the meantime, while they're waiting to get that definitive treatment. So that puts a significant pressure onto kind of other parts of the system, which is you know, it is just, I think, unavoidable given where we are at the moment. BMA Scotland are trying to support primary care and looking at kind of workload, ways to kind of manage workload. I've put a link in there for colleagues, which we can share after the meeting. It's also worth mentioning there's national work on key enablers, so accommodation, IT infrastructure, and issues like digital prescribing, all of which will eventually bear fruit in terms of releasing clinical capacity. Those have all been subject to delays nationally, and again, I think that is, you know, I think in large part that's been related to COVID as well. So, you know, I think it's just important to paint give the context and paint the backdrop really that we're operating under. And you know, smaller practices, we have to, you know, it is inevitable if you're a small organisation with one GP, if that person is off sick with COVID or unable to come to work at short notice, inevitably that creates much more sustainability challenges than larger practices where there's at least the possibility to cross cover. I'll move on to the final slide, if that's okay, James. So we've talked a little bit here about what we've been doing to try and support sustainability of primary care, because obviously all of our GPs are locally across the border independent contractors. So we've obviously got a team in place to try and offer direct and indirect support to practices. We've got practices over the last sort of 12 months where we've had you know, members of our PCIP team actually going into the practice to provide you know, clinical cover, because we simply haven't had the capacity to do so within the practice. So we do kind of both, you know, indirectly and directly support practices wherever it's necessary. In terms of the recruitment challenges, we've held 2 job fairs annually so far. We're aiming to run that as an annual affair. That's where we get all of the final year GP trainees who are at any of the practices across Clyde. So that's Renfrewshire and a wee bit of Inverclyde, and we invite them along to meet local practices who are seeking to recruit GPs in an effort to retain them in the area. You know, if they've worked in Renfrewshire, or Inverclyde, they've obviously interfaced with our local hospitals. They know the referral routes. Hopefully, they've built built positive relationships with patients and colleagues, it's really important to try and retain them locally if we possibly can. We're also working with other colleagues. So, for example, we've got a Scottish Ambulance Service fixed-term project supporting home visits. So we've got an advanced practice paramedics who are rotating, and they are supporting a number of practices initially in Paisley to undertake house calls where the GPs and the paramedics agree that it's an appropriate clinical case for them to do so. Obviously, with the support of GPs, and they can lift the phone if they've got any concerns on that. Additionally, just touching on the visa sponsorship program, an issue for primary care in particular, because it's a slightly shorter training program than hospital-based programs, because only a 3-year program of training, people may come to the end of their visa and no longer have the right to remain and require a visa in order to do so. Obviously, that's something that small practices haven't been aware of, or kind of haven't been in a position to do previously. We've worked with our local practices, a number of local practices. We've both sort of supported them and funded them to apply to be visa sponsors, and that's helped them recruit GPs who are international medical graduates who've trained locally, but obviously we want to retain locally. And I think that's informed some Scottish Government national guidance that's being launched later this week, and we've been a sort of a pathfinder in that as well. So I'll stop there and hand over to any questions, if that's okay.
Well, thanks for that, Stuart. I was just going to ask with regards to, I mean, I think we went through a lot of important things there, and I'm going to ask you about ear syringing, but would that be something that would be done in the treatment room, Stuart, or is that something that would be looking at mobile? I know there was some sort of chat about maybe having a mobile facility that we could be taking out.
Yeah, so I think the mobile facility we're looking at specifically as an option for the villages for Bridgeweir and Houston, where there've been those specific issues around access to Linwood raised. So that would be for that specific area. I think with irrigation and microsuctions, that's for people for whom washing irrigation out the ears wouldn't be appropriate. We're probably going to have a number of sites that might be centralised within the HSCP, where we might say a couple of places would do the microsuction, for example, but the ear irrigation, and I'll defer to Pauline, is a quite an easy bit of kit to move around, and once everyone's trained up in irrigation, that isn't something that is difficult to provide from every site we're currently offering CTAC services from. But yeah, it'd be based in that list of centres that we've shared on the next slide.
Because it's a real welcome development there, sure. But thanks. Francis, I see your hands up. Oh, sorry, I'm out of order. We've actually got John Matthews first. You're actually third, Francis. John, if you'd like to come in.
It's fine for Francis to go ahead of me. On you go, Francis.
Thank you. I was just going to ask how sustainable the arrangement with the Scottish Ambulance Service will be in their own pressures.
Yeah, so I think this is a specific cohort of paramedics who are advanced practitioners. So they're advanced practice paramedics, a bit like our advanced nurse practitioners. It's a different role and a different different scope of practice. So that they're specifically trained for this type of work, and this is it's a funded arrangement effectively, where we've managed to cobble together the last bits of our reserves before they were repatriated elsewhere, and agreed that as a sort of 18-month project with SAS. Obviously, we don't currently have funding beyond the 18 months, but as part of our kind of recovery program, whilst general practice is in the situation it's in, and we hope it will, things will improve in 18 months. But certainly, it's definitely sustainable for that 18 months, and we've got a sort of a memorandum of understanding with them.
Okay, thank you.
Fiona, your hand's up next.
Thanks. Sorry, I thought it was John.
No, it's just I'm all out of sync.
All right, that's okay. It was really just to say how pleased I am that we're actually addressing the issue in terms of Bridge of Weir.
Yeah.
The accessibility there is complex for people, and certainly it's helpful if we're looking at a mobile solution. And I'm glad that we've got an interim arrangement in place for those that find it particularly difficult. Well, a lot of the population, a lot of the patients have cars and drive elsewhere. We do have people that require public transport, and as you know, the public transport has been really restricted and cut in terms of the local community and their ability to do it. I had a number of constituents and patients who came to me in terms of their concerns about the plans, so I'm able to go back and let them know at the next meeting. Thanks very much.
Thank you, Fiona. Right, John, last but not least.
Thanks. I wouldn't want Stuart's presentation to not be noted in the way that it should, because he spoke at 100 miles an hour. But the degree of upskilling that has gone on and is continuing to go on is so commendable, both to the GPs in the sense of senior clinicians' willingness to allow people to come into what was their space. And it's not because they're lazy or we're short of GPs and so on. That's been going on because it's good practice. And, you know, and I just think of some of the things, you know, if you present with blood in your urine, the GP will send you, it won't be a consultant, you'll see, it'll be an advanced practice nurse. And she'll take your hand through to the next room after assessing and use the camera herself and so on and so on, which shortens the time in terms of the anxiety of the patient waiting to know whether there's something serious or not, as well as this whole workload that we're talking about. And I commend Stuart, and Stuart gets commended, and rightly so, in our IJB because he's efficient and quick and observant and so on. It's well deserved. But you know, just generally across the piece, this is what's going on, and we should be. It's because we don't present ourselves that we're not aware of it, or if we do, we think, no, I want to see the doctor. When in actual fact, this upskilling is a highly professional and to be commended. Can I ask you a question, Stuart? Do you know or have contact with John Montgomery in Govan? His deep end. I say that because I recently visited there, wearing my deputy chair's hat of GGC, and he spoke most familiarly and convincingly about retention of GPs, trainee GPs coming to him and so on. And that's the thing, if you don't catch them, then they'll go into the hospital or they won't go into practice at all. I just thought, and John was complaining, well, that's the wrong word, John was saying that perhaps his experience in that practice in Govan had not been picked up in a way that he would have liked. And I just throw that in anyway. Thank you.
Yeah, thanks very much, John. I think the issue with GP training is that some practices will be training practices and others will not. So I think it's fair to say, if you looked at is there a correlation between retention in training practices where you have every year, you know, doctors entering their, it can be their final year of GP training, but also they may be slightly earlier in their career as well. You're much more likely to have less of an issue with workforce, because, you know, I did when I trained down south. I stayed on in the practice because there was a role for me in the practice where I trained, and I think that's kind of been a traditional, you know, maybe slightly an apprenticeship type model almost in primary care. But I think that's the point of the jobs fair that we've run, is that we can allow practices that are not training practices to meet the trainees in practices where there aren't necessarily jobs going that year, to try and retain them at least within Renfrewshire. So absolutely, but happy to take advice, and I meet with my other CD colleagues from Glasgow City, so hopefully they will have gleaned any of those pearls of wisdom to share.
Thank you, Stuart. Thank you for that. Okay, any more questions or comments for Stuart? No, quite happy with that. Well done, Stuart. Thank you. Thank you once again. Which takes us on to the next item, which is item 11, the property accommodation update. And is that getting done by Sarah? Is that yourself, Sarah?
It is indeed, and I'm conscious of the time as well. So, I won't go through this in too much detail, but happy to take any questions at the end. It's just really to highlight that this is an interim update for everybody, because we would be wishing to bring a full strategy to the IJB. However, it's very much dependent on our partner organisations, who both sides are currently working on their own estate strategies. So once they're complete, we'll take the information from that and produce our own strategy in light of the outcome of those. So this just basically highlights key areas of activity over the past few months, and it also explains some of the way that we are working now, the lessons learned really from COVID, the need for us to change the way that we use our accommodation because of the increase in teams. And if you go back to Stuart's recent presentation there, that we've got, an additional 120 staff that we've had to accommodate. That's been quite difficult for us because we have no new buildings. So we've had to reconfigure a load of our buildings and the way that we use office space. And we actually want to, as part of our need to recruit and retain staff, we need to work differently as well. So that needs to be a more flexible approach, more hybrid approach for those staff who can work either from home if they choose to, or work more flexibly with their different hours. So that's contained within the report there. One of the other areas that I would like to highlight is in relation to Bishopton Dargaville, just to provide comfort to members that the actual design of the proposed facility, which is actually just subject to planning permission, we're just awaiting the outcome of that, and we should have that very, very shortly. Just want to make sure and to provide comfort that we used independent modelling of population growth for the design of the building, and it actually does allow for it to be almost doubled in size should that need arise. So it's just to really flag that up to people, just to make sure that, you know, to provide that comfort for yourselves. And there's also a list of all the different works that we've done right across all of our accommodation in both health and social care sites. But I won't go into that detail just now, but I'm more than happy to either take questions now, or if anyone wants to come back to me if they've got any queries at a later date. So happy to open it up to everybody.
Okay, thanks for that, Sarah. I don't think there looks as if there's any questions for you just now, Sarah, so I think you're okay in that one. If we can just agree the recommendations, then that's just noting the report.
Thank you, and it's for the first really positive report I've got to bring to the IJB, and it's quite exciting for me to have nothing negative to say, so it's really good.
Sarah.
Thank you.
Thank you, Sarah. So that takes us on to item 12, which is the Renfrewshire Alcohol and Drug Partnership Annual Report Survey.
Thanks, Jennifer. So my name's Donna Rees, so I'm the coordinator for the Alcohol and Drug Partnership. So I suppose the purpose of my attendance this morning is to bring you the Alcohol and Drug Partnership Reporting Survey for the period 22-23 for your approval. But just before, I will be very brief, but just before I start, I'm just going to go back to one of the points that was raised earlier in the meeting about the MAT standards. So it's just to give you an update in terms of where we're at in performance for Renfrewshire. So Renfrewshire's actually doing very well. So we're currently green for MAT 1, 2, 4 and 5, and we're actually ranked joint second nationally against Glasgow City, so we're actually doing really, really well. And the MAT 3, which we're scoring amber just now, we're confident that will be green because we'll be delivering that in-house going forward. And then obviously MAT 6010 will be measured going forward and will be reported next April. And again, we can bring back a report to kind of show our performance around that as well. So I thought I would just give you that wee quick update. So I just need to emphasise the template itself was designed by the Scottish Government, so it doesn't really capture a lot of rich information, but what it does do is captures a range of actions which are aligned to the priorities relating to the national mission, which was set up in response to the rising number of drug-related deaths in Scotland. So the data captured within the survey that will help us to identify gaps, and it will shape key actions going forward for us as an ADP. And nationally, the data will also be used to monitor the impact of the Scottish Government's National Mission Action Plan. I think it's prudent to mention that we will be refreshing our ADP strategy, and we will be developing a high-level delivery plan, which will provide more in-depth information compared to what you see in front of you today. And with your permission, we can actually present that to a future IJB meeting by our independent chair, which Christine, who has already introduced, John Goldie. So that's a great appointment going forward for the ADP. So it is exciting time. So I don't know if John wants to come in and say a very brief couple of words. John.
Thanks, Nora. Yeah, thank you, Chair, for allowing me to do that. Really, just what I want to say is really a thank you to Christine and to the IJB for being very forward-thinking and actually setting up this independent post. It's the right thing to do, but sometimes not always the easy thing to do. But I think the level of scrutiny that this will bring on the work of the ADP, I think, will benefit Renfrewshire as a whole, and the evidence base of independent chairs across other ADPs have delivered in that.
Sorry, John. Francis, could you turn your mic on, please? I'm getting a bit of feedback. That's us. Right, John, sorry about that. On you go.
Yeah, no, what what I was going to really say is the point that Donna was saying there in terms of the survey report from the Scottish Government. It's quite a dry document, and it covers the points of interest clearly, which are important, but are very much of interest for the Scottish Government. What I would be really quite keen in doing in terms of the refresh we're doing for the ADP for Renfrewshire is having a much more localised report, which maybe the members would have a greater interest in terms of what's actually happening on the ground within Renfrewshire. As part of that process at the moment, I'm spending a bit of time going around the present ADP members. But what I would find really useful, and if it would be useful for the IJB members, is if there's a possibility of having some one-to-one time with some of the IJB members to have a conversation around what they feel are the important areas of development as they see it for their services or for their constituents. I would very much welcome that. So it's really just to put that out there, Chair, as an invitation that I would very much appreciate going forward to allow me to try and carry out some of the duties as the independent chair. So I'm not going to say much more because I'm very conscious of time.
I would welcome that, John. I think that's a great idea. Absolutely. So we'll schedule some time in our diaries and we can sit down and discuss that. That's absolutely. No, I'm glad, because I actually began to worry that I'd missed you in the agenda. I thought, where is John? I've gone to the last item here and I haven't heard from him. So no, I'm delighted to do that, John. Absolutely. And do we have any questions or comments? No. Okay then. We just agree the recommendations then, and agree that we'll schedule a little date in the diary for us with John. Christine can take care of that. And that takes us on to the last item, which is the date of the next meeting, which, by the way, is the 24th of November. Can you believe that? Nearly Christmas. We're nearly jingle belling it. Christine, I see your hands up.
Jennifer, I'm just wondering if we can ask Mags as chair of the audit committee for a quick verbal update.
Good idea.
The meeting was only last Monday, and that's why it's not noted on the agenda.
Right, absolutely. And I'm delighted, Mags, that your contribution that changed the RAG rating as well. So where are you? I can't see you.
I'm here. Thanks, Chair. Thanks, Christine. I'll keep it very brief. Yeah, so obviously we did recommend approval of the accounts, which we picked up earlier in today's agenda. We also, as is good practice, had a private meeting for the members of the audit committee with the external auditors, which is just an opportunity, given the relationships, that they have an opportunity to speak to us directly if there's anything they wanted to raise, which, just for clarity, there wasn't anything to bring up that's not already in the reports and publicly available. So nothing else to report there. We also had regular updates from internal audit and agreed to take forward a self-assessment process that we'll do. Again, good practice, because there's new SIPFA guidance around what audit committees should be doing. So we also had updates from health and safety and our public interaction reports. But there's nothing I need to escalate to the IJB, but that's just a general canter through.
Thanks for that, Mags. Okay. So we're all quite happy with that then. We can just agree the date of the next meeting being the 24th of November, and it'll be Microsoft Teams. Okay, that just leaves me to thank you all for your attendance this morning and your support in getting through the first meeting. And I look forward to seeing you all again soon, okay?
Well, thanks to the chair. Didn't the kid do well?
Well
done, Jennifer. Well done.
Thank you.
Thank you.
Thank you.
Take care.
Thank you.
See you
Thanks,
soon.
Bye.
Bye-bye.
Bye-bye.
A good weekend, everybody.
Yeah, you too.
Yes.
Thanks. Bye.
Bye, everybody.